Welcome to part 2 of parenteral medications. We're going to be discussing how to prepare and administer injections in this part. Sub-Q injections typically use a 1 to 3 ml syringe. 1 ml syringes are hard to find, and if we do find them, we call them TB syringes a lot of places. TB syringes usually do not have a removable needle, so you use what you're given. If you are using a 3 ml syringe, you do have to choose your own needle. Sub-Q injections usually require smaller size needle, so a larger gauge number, usually a 25 to 31 gauge. The needle length is typically a 1/2 inch to 7/8 inches. And then insulin syringes are their own special type of sub-Q needle, and they always have an orange tip, and the units of measurement are in units, not in mLs. Intradermal injections typically have volumes of 0.1 ml, so you're going to use a 1 ml syringe, that TB syringe. Needles on these are usually 25 to 29 gauge, and usually they're about a 1/2 inch to 5/8 inches, but again, it's going to depend on what 1 ml syringe your facility buys. IM injections are typically no more than 3 mLs in volume, as the muscle can't handle much more than that, so we're going to use a 3 ml syringe. If you have one of the very few IM injections that's more than 3 mLs, you're actually going to give it to them as 2 separate injections. The needle gauge is going to depend on the viscosity of the fluid, but generally we're going to use a 19 to 23 gauge needle, so it is going to be a little bit thicker than that sub-Q needle. The length is going to depend on your patient, but remember, we need to get that tip into the muscle. So depending on the location you choose, the amount of sub-Q tissue the patient has, and the overall size of the patient, you could use anywhere from a 1-inch needle to a 3-inch needle. Most commonly, you're going to see about a 1.5-inch needle being used. And really what we want to use the smallest needle possible while making sure that we're definitely getting it into the muscle. When it comes to drawing up medications, I really want you to refer to your specific skill videos on how to draw up each of the medications. So please refer back to your skills videos and books, but we're going to practice all of these in person. So when we draw up our medication into a syringe, we need to make sure that we label our syringe with the patient's name, date of birth, medication name, dose, and expiration date so you can complete your third check. You can't do your third check without all of that information. When we draw up medication, it's kind of inevitable that we're going to get some sort of air in that syringe. The best way to get rid of these air bubbles is by pulling back on the plunger to get all the fluid out of that needle. So we're actually going to pull down on that plunger and get some more air in that syringe. Then we're going to hold the syringe with the needle pointed up, and we're going to gently tap on the side of the syringe until those bubbles accumulate at the top. I personally use a pen for this because when I flick it with my finger, it makes my finger hurt. Once all the air is at the top of all the fluid, we're going to slowly push that plunger up until the air is expelled out of the needle. Make sure you get the plunger to the correct dose, and then you're going to recap using the one-handed scoop method. If the medicine is an irritant, you're going to want to change that needle. And if it's an IM injection, you want to change that needle. We want to make sure that the irritant isn't on the needle itself because that's going to make the injection hurt more. And with an IM injection, we want that needle to be as sharp as possible, and it does get a little dull going through that rubber stopper. And then we also need to make sure that we label our syringe so that we can do our third check. We will be practicing this in class, and getting the air bubbles out really is an art form, so we will definitely practice this. When we're administering injections, we need to choose the correct site according to the anatomical landmarks. If you don't do this, you can actually cause some nerve damage, bone damage, or maybe inadvertently ejecting into a vessel, which then would turn your injection into an intravenous injection, which we do not want. When we're actually giving the injection, we need to make sure that we maintain stability of the syringe when it's in the person's body so it doesn't rock back and forth, because that rocking back and forth motion is really painful and it's causing more tissue trauma. So when we choose the location to give a subcutaneous injection, we're looking for locations based on the fat pad sites. So those areas of the body where we all have a little bit extra fat going on. We need the tip of this needle to end up in that fatty subcutaneous layer, so we go wherever we can find fat, and I personally say wherever we can pinch an inch of fat. Usually the lateral arms and the thighs and the abdomen have the most amount of fat. Sometimes it's the back of the upper hips. Those areas are really far away from bones and blood vessels. But if you do use the abdomen, we want to make sure we stay about 2 inches away from the umbilicus. If you're giving an anticoagulant, we usually always use the abdomen. And then this little picture right here just shows kind of the most common places for sub-Q injections. I will say that the back, those subscapular regions, I have never used before, but all the other regions I have used. When we administer sub-Q injections, we make sure we do our 3 checks and then don our gloves. There are some schools of thought that will say you don't need to give gloves for injections, but for me, there is a chance that we're going to touch blood, so I always use glove, and I'm going to expect you to do the same as well. You'll then select your site for injection and prep the skin with an alcohol prep pad. Next, you're going to remove the needle cover, and you're going to grasp the skin with your non-dominant hand. We are pinching an inch, okay? We're pinching an inch of fat when we're doing this. You're going to insert that needle at a 90-degree angle if the patient has enough fat. If the patient is very thin or if they're a child, you can go in at a 45 to 60-degree angle to make sure that tip of the needle stays in that fatty layer. You're darting the needle into the skin. You're not inserting slowly. Next, you're going to let go of that tissue fold. You're going to stabilize the syringe using your non-dominant hand. If you're giving an anticoagulant, you don't let go of that pinch. You're then going to inject your medication, and you're going to remove the needle, and you're going to activate that safety mechanism immediately. You're going to hold pressure at the injection site with a gauze pad for a few seconds, but we're not massaging the area. Okay, all we're doing is just holding that gauze pad on there to make sure it's not going to bleed. When giving subcutaneous anticoagulants, there are some tips that I want to share with you guys. The 2 most common sub-Q anticoagulants are heparin and Lovenox. Lovenox is actually a low molecular weight heparin. Lovenox usually comes in pre-filled, pre-needled syringes like this picture that you see. You may need to adjust the amount of medication in the syringe depending on your patient's dose because they are pre-filled with a certain amount of medication in them. Heparin comes in a vial, so you're going to need to draw that up into a syringe. I typically use a 1 ml TB syringe and a 25 gauge 5/8 inch needle if you have the ability to change your needle. If not, I just use whatever needle is on the TB syringe. If you can change your needle, please change it after you draw up the medication. It's going to help prevent heparin from tracking into the tissue and causing a bruise. But again, we use what we have offered for us. The abdomen is the preferred site for anticoagulants. And remember, we want to stay 2 inches away from the umbilicus. We're going to make sure that we rotate sites. We don't want to be poking them in the same spot in their belly over and over again. And we have to document where we gave the medications, so people who are working behind you know where you gave your last shot. And then because anticoagulants have a high risk of bleeding, you're going to instruct your patient to watch for the signs and symptoms of bleeding, and then we're going to monitor for those as well. We also need to monitor the appropriate lab work. For heparin, we monitor the PTT levels. Lovenox doesn't really have its own blood coagulation time, so that kind of depends on what provider you're working with. All right, now IM injections. So there are 4 types of IM injection locations on the body: ventrogluteal, vastus lateralis, deltoid, and dorsogluteal. The dorsogluteal site isn't recommended for routine injections, but there are a few injections that must be given in that specific region. They are not common medications, so in block 1, we actually advise you not to use this location as it's got a really high chance of hitting the sciatic nerve, which causes significant amount of pain and nerve damage, and there are major blood vessels in that area. So unless you are using those very specific medications that have to be given dorsogluteal, we don't want you to use them. To give IM injections, you need to identify the locations accurately and definitely rotate those sites to prevent overuse in a muscle. Make sure you document where you're injecting so others after you can rotate as well. And then I'm going to discuss each injection location on their own slides. When you give IM injections, you want to make sure that you stretch the skin. This is going to help move that fatty tissue layer out of the way and give you the best access to the muscle. Then you want to stick the needle in the patient at a 90-degree angle. And just like with sub-Q, this is a darting motion, not slow motion. Then you want to stabilize the needle with your non-dominant hand and shoot or inject the medication. Patients are generally anxious due to the potential painfulness of this procedure, and some of the ways to get them to relax include allowing them to assume a position of comfort that's going to reduce their muscle strain, have the patient dangle their arm instead of hanging it or resting it on something, and if you're using that ventral gluteal site, have them lay on their side with their knees bent with one leg in front of the other. All right, the deltoid muscle. The deltoid muscle is used a lot for IM injections as it's the easiest location to get to and it has the easiest landmarks. That's that upper arm injection that a lot of us get. That doesn't mean that it's the best location though. It's really a location of ease. The radial and ulnar nerves are right there following along the humerus, so there is a potential that we hit some nerves. And this site should only be used for small volume injections like vaccines and volumes of 1 ml or less, and with no greater than a 1-inch needle unless your person has a lot of muscle. The deltoid is a bad location for irritating medications like the tetanus injection, but a lot of people give the tetanus injection there anyway, which is why it hurts so bad. When you're looking for the landmarks for the deltoid muscle, you need to find the acromion process. That is the bone that kind of goes across the top of your shoulder right there. And then you're going to do 2 to 3 fingers below that acromion process, and then you're going to find that triangle-shaped deltoid muscle, and you're going to want to inject into that medius part of that muscle, kind of right where that little triangle is in that second picture. The ventral gluteal site is the most preferred injection site for adults and anyone over the age of 1, but it's not used very commonly because 1, look how the patient's laying. If you're going for an injection at CVS or something, it's not like they can get to your butt that easily. And 2, it's a site that most people don't practice. We in Block 1 want you to use this as the preferred site, so this is the site that we're going to have you practice and going to have you test on. This location is away from major nerves and blood vessels, and it's very easy to reach in a hospitalized patient, but like I said, it's not very easy to reach in a non-hospitalized patient. Here's a little bit closer shot of that site. It really is kind of the side of your hip. You've got a good little muscle there on the side of your hip. To do this injection, position the patient on their side if possible. It can be done with them laying on the backs. It's just not as easy to get to. We'll practice this on our classmates. Flexing the knee and the hip is going to help with relaxation of that muscle. So what you're going to do is you're going to place your palm of your hand over that greater trochanter, which is kind of like your little hip joint right there. You're going to use your right hand if you're using the left hip for injection, and you're going to use your left hand if you're using the right hip for injection. You're going to point your index finger towards the patient's anterior superior iliac spine. That's the front of your pelvis bone right there. You're going to spread your index fingers along that iliac crest, and you're going to kind of form a little V shape with your pointer and your middle finger. You're going to point your thumb towards the patient's groin, and after finding the site, you're going to like either make a little dot there, or you can use like the corner of your alcohol wipe to kind of put a little marker there on that site so you know where to go. If they have like a freckle right there, that's a great way to use a landmark also. Next, we have the vastus lateralis. This is a very easy location to find. It's very easy to inject here, but it can make ambulation very painful if you're giving an irritating medication. This is the preferred site for injection for little ones under the age of 1. So anybody who has kids, if you remember when they got their vaccinations in their first year of life, they were getting a lot of them in their legs. The vastus lateralis is found on the anterior lateral aspect of the thigh. It's about 1 hand's breadth above the knee and 1 hand breadth below the knee. So it's kind of right in the middle of your thigh bone. It's not midline of the thigh, and it's not the anterior of the thigh either. It's kind of in between the anterior of the thigh. So it's kind of above midline. So as I'm looking at my thigh, the top of my thigh and the bottom of my thigh is on my chair. I'm not going into my thigh at a 90-degree angle. I'm kind of going a 45-degree angle down from the top of my thigh, and I'll show you this in class. When we give IM injections, we should be using the Z-Track method. And if you've gotten an IM injection anytime in the past forever, you notice that most nurses do not do this. But the Z-Track method is the recommendation for all IM injections, even though it's hardly done. What it's going to make you do is create a zigzag path in the muscle. So when you let go of the skin, it's actually going to seal the medication into the muscle itself, which is going to reduce leakage into that sub-Q layer, making it hurt less afterwards. And if you can remember your TB injection, or not your TB, your tetanus injection you got in your deltoid and your arm hurts for days, it's because they're not using the Z-Track and it's an irritating medication. There is a picture of what this looks like on the next slide, so just hang tight. When we do the Z-Track injection, we're going to first clean the skin with alcohol, and then we're going to pull the subcutaneous skin and tissue over about 1 inch to 1.5 inches laterally. That amount doesn't matter as long as you're actually pulling the skin, and you'll see that in class. Then you're going to insert the needle deep into that muscle. You're going to stabilize the syringe and inject your medication. They say to wait 5 to 10 seconds after injecting the medication, holding that syringe steady before you withdraw that needle and release the skin. And it's really going to depend on who you're giving this injection to. If you're giving an injection to a little kid, you do not have 5 to 10 seconds to wait. Those kids are moving like crazy. But if you have a pretty willing victim who's an adult who's not going to move on you, you can hold it in there for about 5 to 10 seconds. After you withdraw that needle and release the skin, you're going to hold a gauze pad over that site because IM injections do tend to bleed a little bit more than the other injections. And you can apply a Band-Aid as needed. So here is a picture of what that Z-Track method looks like. The left side picture shows that skin and that subcutaneous layer being pulled to one side while they're injecting that medication. And then the right side is showing you what that injection track looks like after we have withdrawn the needle and released the skin. So if you can see, that medication really is stuck in that muscular layer, and it doesn't really have a way to track back into the sub-Q or into the dermal tissue. That really helps with irritation. When we are giving intradermal injections, these are going to be administered just into that dermis right below the epidermis. So these are really superficial injections. These have the longest absorption time of all parental routes, and this site is commonly used on that inner surface of the forearm. It's usually 1 hand's breadth below the antecubital fossa, or they can use the upper back. Normally that forearm they're going to be using for TB tests. The upper back they use for allergy testing. We want to make sure that we're avoiding any areas with scars, blemishes, or abundance in hair if possible. You're going to prepare your medication in that 1 ml TB syringe with, if you can choose, a 1/2 to 5/8 inch long, 25 to 28 gauge needle. But like I said before, most TB syringes have attached needles, so you're going to use what's available to you. You're going to clean the site with alcohol, and you're going to hold that skin taut. You're going to insert that needle at a 5 to 15 degree angle, so very shallow angle. You're almost going in flat against their arm. And you're going to advance that needle about 1/8 of an inch. This is going to be very shallow, and you should be able to see that needle point under that skin. You're going to inject very slowly to form a bleb or a wheal right under that skin. And if you look at that picture right there, do you see how it's got a little circle there kind of forming where that needle is? That is a bleb or a wheal. Same term, different terminology. You can see either one. We do not massage this spot, and usually we don't put a Band-Aid on it if it's not bleeding. This picture is just showing you how to hold your hands to keep that skin taut while giving that intradermal injection. And if you see how shallow that angle is, I mean, they're almost using that needle almost skin to skin right there. Now, intravenous medication is considered parenteral, and it is the fastest absorbed route of all parenteral medications. IV medications, the medication goes directly into the bloodstream. It has immediate effects, but we do not teach you any IV medications in Block 1. You're going to learn more about IVs in Block 2 and Block 3, so you do not need to know anything about IVs in Block 1, but I do want you to know that IV is going to be that fastest route of absorption for all parenteral routes. And this is the end of parenteral medications.